Hi, this is Robin Mears. I'm giving my SOAP note presentation for FNP 597, Clinical Residency in Practice Management, under the direction of Dr. Christina Davis. I have a geriatric neurological patient. This is LF. She's 85 years old. She was born in 1/1 of 1940. She's a white female. She arrived at the clinic by herself, drove herself to the clinic, and she is her own reliable historian. Her chief complaint is she says, I've been having trouble finding my words from time to time, and it seems to just come and go. Started about a month ago. She said it started about a month ago. Her daughter almost took her to the hospital a couple of weeks ago, but then it got better. Episodes have been lasting anywhere from 30 minutes to an hour. The last one was on 8/5 of 2025. She reports inability to speak but understands fully at the time of the episodes. Nothing seems to bring them on or make them better. They just kind of come and go on their own. Reports that 2 out of the 3 episodes have been happening early in the morning, and she denies any pain or headache. Past medical history of hyperlipidemia and hypertension. Past hospitalizations were in 2021. She was hospitalized with COVID. And then she had a cholecystectomy back in 1998. No psychological history. Preventative care, we always go over that at our clinic. So low dose CT, she never smoked, so that's not applicable. Flu shot, she did that in 2024. She's fully vaccinated from COVID and boosted as well. Pneumonia shot was in 2020, shingle shot in 2010. Allergies, she has no known environmental, food, or drug allergies. Medication, she takes 40 milligrams of atorvastatin, 1 tablet at bedtime for hyperlipidemia. Losartan, 20 milligrams, 1 tablet daily for high blood pressure. And hydrochlorothiazide, 1 tablet daily, and that's also for high blood pressure. Significant family history, mother died of heart problems at 65. Her dad died later of COPD, but that's not really relevant. Social history, she lives in an assisted living facility in the self-care side. She does take care of all of her ADLs. She only gets assistance with housekeeping once a week, and then she has her evening meal at the cafeteria downstairs. She does have advanced directives in place. She never smoked. She does drink 2 to 3 drinks of alcoholic beverages per week. No illicit drug use, and denies marijuana use. Review of systems, constitution. She denies fever or fatigue, weight loss or weight gain of 10 pounds in the last month. Cardiovascular, she denies dizziness, heart palpitations or chest pain, shortness of breath, orthopnea, shortness of breath with activity. She denies respiratory. She denies any shortness of breath with exertion, orthopnea, wheezes, productive cough, or non-productive cough. Neuro, she does report intermittent periods of expressive aphasia lasting 30 to 60 minutes. She denies hemiplegia, facial drooping, receptive aphasia, vision changes, vertigo, or loss of balance. Musculoskeletal, she denies any weakness, loss of balance, or gait abnormalities. Vital signs, she was, heart rate was 68, blood pressure 145 over 62, temperature was 98.4, O2 sat was 95% on room air, respiratory rate was 18, 0 out of 10 pain. She's 5'3", weighs 115 pounds. Her BMI is 20.4. She's a cute little thing. So it's important to note that these blood pressures were taken. She'd already taken her blood pressure medicine that morning. So this was about a 10 o'clock appointment. So she had already had her blood pressure medicine. General survey, she was sitting actively in the chair. Respirations were easy and unlabored, and she greeted me as I entered the door. She's well groomed without odor, halitosis, or dishevelment. Skull is not normocephalic, atraumatic, without masses. Patient's facial expression and facial contours are normal. Parotid glands are not enlarged. The sinuses are non-tender. Eyelids are without lesions. Sclera is white and the conjunctiva is pink. Pupils are equal round and reactive to light and accommodation. There is symmetry in the nasolabial folds with no facial droop. Cranial nerve 8 was intact by whisper test. And then cardiovascular, her skin is pinkiform and dry. There's no JVD, clubbing, or cyanosis. The chest is symmetrical without any visible scars, masses, hematomas, or lesions. There's no heaves, lifts, or thrills upon palpation. No bruits heard, including the ones over the carotid arteries. Her heart rate is regular, with a regular rate and rhythm, S1, S2, without S3, S4. No murmurs appreciated. The point of maximum impulse is at the mid-clavicular line, at the fifth intercostal space. Capillary refill is brisk, and there's no pitting edema to the lower extremities. Respiratory rate, her AP ratio is 1:1. Chest is symmetrical without any visible scars, masses, lesions, or hematomas. Respiratory excursion is equal with full range. No tactile phragmitis. Upon auscultation, bronchovesicular lung sounds were heard, anterior and posterior. Neurologic, cranial nerves 1 through 12 were tested and grossly intact. Deep tendon reflexes of the upper and lower extremities were symmetrical. Graded 2 out of 4. Plantar reflexes are good. Cerebral function is intact. Romberg test is negative. Gait is normal. Sensory testing by pinprick, light touch, position, and vibration were all intact. Musculoskeletal, upon inspection, the alignment of the major joints and spine were symmetrical. There are no deformities and misalignments. There's no ecchymosis, erythema, lacerations, subcutaneous nodules, or signs of muscular atrophy. Upon palpation, there's no edema, diffusion, temperature changes, tenderness or crepitus. There's the bony landmarks are normal, and there is a physiological continuity of anatomical structures. Range of motion testing was good. Muscle strength was 5 out of 5 on all 4 extremities. And so differential diagnoses. Number 1 is essential hypertension. Her blood pressure is not at goal. It should be less than 140 or 90, and she's over the 140 mark after she had a blood pressure pill. So we're not sure what she would have been before that. The AFP strongly recommends clinicians treat adults who have hypertension to a standard target blood pressure of 140 over 90 to reduce the risk of all-cause cardiovascular mortality. That's Cole et al. 2022, page 4. Transient ischemic stroke is the second diagnosis, potential diagnosis, G45.9. Patient has transient episodes of expressive aphasia without receptive aphasia, vision changes, facial drooping, weakness, gait changes lasting 30 to 60 minutes, no episodes most episodes occurring in the morning. Acute onset of neurological symptoms followed by a complete resolution is suggestive of TIA according to Emin et al. 23, page 1. And cerebral stroke syndrome is the third diagnosis. Expressive aphasia for 3 episodes without receptive aphasia, facial drooping, hemiparesis, vertigo, or loss of balance lasting 30 to 60 minutes. Sudden neurological dysfunction causes focal brain ischemia with imaging evidence of acute infarction defines acute ischemic stroke. So we don't have the imaging to diagnose the stroke. So most likely she's having TIAs secondary to hypertension not being at goal and hyperlipidemia. Her repeat blood pressure was actually a little higher, 150 over 72. We're going to get a CT of the brain with and without contrast and a carotid ultrasound. We're going to educate her on a DASH diet, slowly exercising up to 150 minutes a week. She is in the frail age group. She's 85, so we're encouraging her to do that slowly. And then We're going to give her blood pressure log and ask her to take that twice a day. Self-management of blood pressure is recognized to improve patient empowerment and adherence to treatment, according to McCarthy et al. 2024. We're going to give her, ask her to take her lisinopril at nighttime and her hydrochlorothiazide in the morning. That's going to give her 24-hour coverage for that blood pressure and hopefully reduce those morning symptoms. We're also going to tell her to call 911 for any signs of a stroke. We're going to teach her the BFAST acronym, and that time is BRAIN. Designation of an acute stroke team that includes physicians, nurses, laboratory / radiology panel is recommended. Patients with stroke should have careful clinical assessment, including neurological examination, according to Powers et al. 2019. We're going to increase her lisinopril to 30 milligrams by mouth every evening. And then if the target is not goal at 1 month of therapy, we're going to add probably an additional 10 milligrams. She is older, so we're going to go slow with her. And that's according to Armstrong 2014, page 503. We're going to refer her to neurology and consider vascular surgery if the carotid ultrasound proves positive for stenosis. She does have a history of hyperlipidemia, so that is a potential cause of these ischemic, transient ischemic attacks. We're going to follow up with her in 2 weeks, check on her blood pressure. We're going to check on that CT scan. And then we're going to once again advise her to call 911 for any returns of symptoms of a TIA, using that BFAST acronym, as the TIAs could be preceding a CVA. So she definitely needs to go to the ER. And that is my case. Your references are listed below. Thank you so much.